Welcome to the SIBO Doctor Podcast, hosted by Dr. Nirala Jacoby. Medical experts join us to discuss functional digestive disorders, clinical practice and research as it relates to SIBO and associated conditions. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. Head over to thesibodoctor.com and sign up to the SIBO Mastery Program and take your SIBO knowledge to expert level. If you're a patient, you can sign up to the SIBO Success Plan and beat SIBO for good. Please note, this podcast series is not intended to diagnose or treat medical conditions. Ask your doctor before initiating any new treatments. And now, over to Dr. Jacoby and the latest episode of the SIBO Doctor Podcast.
Welcome to another episode of the SIBO Doctor Podcast. And with me today is a returning guest. It's Dr. Farshid Sam Rahbar, who's a holistic and integrative gastroenterologist and the medical director at the LA Integrative Gastroenterology. In 2013, he delved into the relationship between tick-borne Lyme disease with a special interest in gastrointestinal manifestations. Since this time, he has witnessed clinical patterns involving the role of infections, acute and chronic, in causing ongoing GI-related conditions and symptoms. And Dr. Rahbar's special interest areas also includes dysbiosis, SIBO, and leaky gut. And it's been 3 years that you've been on the podcast, Dr. Rahbar. Lots has happened since then. So welcome back to the podcast. So nice to have you. And actually, 3 years ago, you talked about SIBO and Lyme disease. That was pretty revolutionary. And since then, both of us have actually given presentations on methane at medical SIBO conferences. And it seems like we share this common fascination with methanogens and methane production. Now, recently, you also commented on the connection between methane and yeast overgrowth, which is definitely something I see a lot in my practice. So I thought it would be great to discuss this on the podcast because a lot of practitioners struggle with both methane and yeast overgrowth in their patients. So really excited to have you on this podcast for this topic. And before we go into that topic, I thought it would be great if you could just briefly outline some of the methane types that you've presented on at I think it was the SIBO Symposium in Seattle, and just the way you categorize or classify your methane patients.
Right. Well, thank you for this invitation. I feel quite honored. And every day as it comes to dealing with SIBO, methane, and yeast, I feel I'm still a student. So I hope everybody has the same spirit of learning as we go along here. The patterns that I discussed in the last year's SIBO conference, it relates to SIBO patterns, and methane is part of it. They're not just methane patterns, but there's SIBO patterns. And we looked at not only the gas pattern, like is it hydrogen or methane, or is it a combination of both, but also the response to the treatments and the outcomes and the behavior of the SIBO. And can we learn from the behavior and change our treatment model, if you will. Now, going back to that, what I called classification, that it was something arbitrarily I put together. I called them from 1 to 10 different subtypes. And just to be able to remember what they do, I gave them a little funny name. So we're going to call them type 1 to type 10, but they also have a name that goes with it. And I'm going to go over that. The type 1, I called it the easy rider. Okay, and the is a type that you have somebody with SIBO, most likely a hydrogen producer. You treat them, and basically it resolves. It goes away. Patient happy. Everybody's happy. And then we have type 2, which is persister, and you treat it. The problem is still. The other one, relapser, a condition that the patient gets better, But then it comes back again as if I have to treat it again. The question is that what's wrong? What is the underlying immune system status that it allows, the SIBO to come back again? And then I call it type 4, the mega gas. You see these numbers that are hundreds, And if you have another scenario where the methane is very high, and I call it the mega meth, okay? And then you have the blend, the both, and then you have the paradox, and that's more like you treat it, and actually the gases, they get worse. I've seen this pattern sometimes. I treat the SIBO, and actually when you repeat the test again, it looks worse. And then the type 8, I call it the incongruent, which means that SIBO gets better, but the patient doesn't get better. There's incongruency between the clinical outcome and the results of the SIBO test, means that the SIBO was there and has nothing to do with the patient's clinical presentation. It was just a biological marker that something is wrong here. And then type 9, I call it a silent abdomen. And this is the one which is interesting because you have a patient who has a lot of bloating, but they don't have too much rumbling and noises and flatulence. It's just a lot of bloating, and they have a SIBO associated with it. But this is what I call silent abdomen because there's not much malabsorption type symptoms with it. And this scenario should be reminiscent of autonomic dysfunction, which means that the nerves may have a problem, and then further investigation in that respect may be necessary. And type 10, which is something we're still learning about it, I call it the flat line or the H2S, and that's something that hopefully when the testing model is available, we can start to use and learn more about it. But the message from this pattern was this, that patterns 2 to 9, they have a high likelihood of being associated with an underlying systemic illness. And that means that one has to think like an onion with layers that may be sitting one after another to look for environmental, toxic exposure, heavy metals, immune dysregulation, stealth infections. And among this last category, there were a lot of patients we saw with tick-borne diseases. That would be Lyme, Bartonella, and Babesia. And just for information, as we speak now, our article is ready for publication, and it has been submitted to editorial for editorial review. They have gone through it. They have given us feedback, and I'm hoping that after we have made the correction, that they would be willing to publish this in an online journal that would be available to everyone. And that's the pattern. Now, obviously, the methane is really fascinating, and I totally agree with you because the main question that remains is what causes these methanogens to grow in an area where the whole gas production ideally should be less than 3. And even though the SIBO consensus conference said, well, 10 and above is abnormal, but I think it seems that for the normal person, the majority should be around 3 or less. How do we get 70, 80, 100 numbers in that area? And what does it mean? How did we get to that point? And what causes these bugs or archaea to basically sustain and survive in that environment, as if my gut has become a petri dish? What am I doing there that it allows this thing to grow? I'll let you ask questions now.
Well, before I go into my first question, I already have probably 10 different questions on what you just said, but I really appreciate the classification, if you will, of the methanogen presentations, because I see all of that in my practice. And I think very often, first of all, we all know that methanogen or methane SIBO, now known as EMO, and I'll let you I think you have some comments about that, or intestinal methanogen overgrowth, is very difficult to treat. And perhaps because there are these different versatile causes or presentations that you've just outlined, it's not as simple as just having high methane. There are a lot of different contributing factors. So one of the reasons we wanted to have this discussion was looking at methanogens and its connection or their connection to fungal overgrowth. And I found that just totally fascinating when you reached out to me with these links. And, when I first started my naturopathic practice, I was known as sort of the yeast queen because I was like everything I saw was Candida related. And, or I should say, a lot of systemic illness that I saw had this gut connection. And this was before I knew much about SIBO at all, if anything at all. This is over 20 years ago. And, here we are. And that methane may actually be connected to a yeast overgrowth. So I let you elaborate what you had communicated to me.
So there's a time in life you get to a point that a thought keeps coming back to your mind and you just can't sleep with it. And eventually I said, what, I got to throw this at Dr. Jacoby and Dr. Siebecker, see what they think, because we were seeing a pattern among our patients, which just started me to think, is it possible that presence of fungus is really necessary for the methane to grow to this level, or at least it could be one factor, in that. And I'm also a believer that persistent fungus is another reason to believe that there is immune dysregulation. Like somebody can have a vaginal yeast infection, give them one fluconazole, it goes away. But what about if the problem is recurrent? And, we can't just get rid of the biofilm. And what's wrong with the immune system that can't really handle the fungus to put it back where it was? So the connection came when we started to see many of our patients who had evidence of methane, they also were showing evidence of fungus. Now let's talk about how did I come to the conclusion there's evidence of fungus, because there is no such discussion in classical textbooks, and this subject is not recognized. We realize in traditional medicine, invasive candidiasis and fungal infections in highly compromised patients. We recognize oral thrush, vaginal yeast, esophageal candidiasis. But as soon as it goes beyond that into the small bowel, we don't have a discussion. And SIFO, or small intestinal fungal overgrowth, I don't think it still has any ICD-9 coding or any discussions. I think physicians are talking about it more, but it's not formal yet, and it may be a foreign language to some of our colleagues there. But it is not inconceivable to say that if we can get a growth of fungi in oral cavity and other parts, the same might have happened in sinus cavities or in the small bowel. It's a nice and warm and dark place, and bugs love to grow. The body has some mechanism that deals with it, but it allows these fungal elements to grow. So we do the same thing you do. We frequently look for risk factors for patients who might have fungal scenarios. And some of those factors could be alcohol, stress, late eating, a lot of carbohydrate intake, use of steroids, antibiotics, and so forth, but also presence of mycotoxins, which is becoming very, very common. Again, this is an area that is not well discussed in traditional model, but the highly sophisticated urine tests that are now available show that some patients harbor, large amounts of mycotoxins showing up in their urine, which may be from inhalation, it could be from the dietary source, it could be exposure to the water-damaged building, depending upon the type of mold they have been exposed. But I'm of the belief, based on what I've seen, that these mycotoxins are immune suppressants, and they commonly promote the growth of their own species. And I say, this is my own family, I'm going to try to let them grow. So when you see a pattern that the fungal elements are there, then some of these risk factors easily show up if we are looking for them. And then among those, sometimes heavy metals for people who eat a lot of sushi, tuna, and things like that. We see it quite commonly in the practice. But how does that relate to the methane? That's another scenario. Say, okay, first of all, what is my marker for fungal element? First, I have to recognize the clinical picture. So I'm going to say, okay, what's your story? The story has to fit, and my clinical judgment has to go with it. But then I may want to do some confirmatory tests. And among those, most practitioners are familiar that there is a urine organic acids looking for almost 8 or 10 different markers for fungal elements. That could be supportive. We consistently use doctor's data lab, and I'm not here to promote one lab, but this is one lab that it does culture for fungus. And when I'm suspecting it, I usually use this lab because they identify the fungus. And I don't believe the presence of fungal growth in man's stool is normal. Indeed, I don't recall any man that I've seen that they show presence of 1+ fungi of rhodotrola or some other strange fungus that they feel good, that I just found this out of curiosity. I mean, usually they have systemic, illness, and there's something else that is going on with it. So we look at the stool analysis, we look at the organic acids. Nowadays, I'm also looking at fungal antibodies, multiple fungal antibodies, probably over 100 of these with IgA and IgG antibodies to see if I can have further evidence. We also check for mold antibodies by IgE to see if we can find additional evidence. But generally speaking, one of these things will show up. And occasionally what we have done is for patients who have had bile gastritis, and I talked about this in my previous presentation, that we feel that the presence of bile gastritis is associated with proximal gut dysbiosis. And we have been obtaining the samples of the duodenal juice and in a rather informal way, checking it for microbiological findings. And part of that is the PCR test of the juice to see if there are fungal elements there. And occasionally we see some level of fungal elements in that one. So this is my ideas, of how I may be looking for those fungal elements. But then some of these patients, we found that they have high methane. And I think in this scenario, to treat the methane, for example, with Xifaxan and rifaximin and with neomycin, it could almost be detrimental, because if you have a fungal scenario sitting in the background, either the patient doesn't get better or they may get worse. And on the other hand, what is driving that growth of archaea with these numbers, whether it's 10 or 20? And now we're seeing some numbers that are really high. Another thing which is interesting with methane is lack of complete clinical correlation. Like you have high methane, but you don't have constipation, or they have diarrhea. It just doesn't follow what we learned, that methane causes constipation. I just think that it may be just a biological marker sitting there in some cases. I'm not saying that treatment of methane is not always addressing the constipation, but I think there are other layers, and I think we need to think about this, especially some of these mega meth patterns are fascinating, because one questions, how did I get to this point, this high level? So when we asked that question and we started to look at the correlation with this common finding of fungal clinical scenario, fungal clinical scenario and presence of the methane, could these two be related? So when I studied this, I asked one question: how do you culture methanogens in the laboratory? And while I was doing a search, I found an article, and I sent you that article. Then I went to their methods and I read it very carefully. They were putting so many chemicals there to make all these methanogens grow, and it was really mind-boggling to go through all of that. And I wish I could get the PhD who wrote this to be on this call maybe one day and discuss it. But the interesting part is that as part of the prep, I saw that they were using fungus to create an anaerobic environment. And we know that fungi, they have interesting features. First of all, you can have fermentation with dead fungus. The concept of having fermentation with dead fungus was published in chemistry some years ago. And I didn't know, this is before I was born. The guy who described this got a Nobel Prize for it. Did you ever hear about this? No, I didn't know. And my time was too limited. Otherwise, I would have gone into the historical part. So I said, okay, so I could have dead fungus there, and I could still cause fermentation and gas and bloating and things like that. But the fungi can also survive with oxygen or without oxygen. So many of them, apparently, they look like fungal elements. I mean, they like the air and the oxygen, and that's why if you have fruit sitting outside, it can, you can see fungal elements can start to grow on that after a day or two. So on the other hand, methanogen, they're actually anaerobic. They don't like oxygen. You can kill them by exposing them to the oxygen. So if they're growing in the proximal duodenum, which there's supposed to be some air floating around, there must be some anaerobic environment created by something else. So it becomes a symbiotic arrangement that the presence of the fungus may actually be promoting the presence of the methanogens. So in our practice, when we find evidence of fungi based on some of those tests that I talked about, or based on my clinical judgment, I tend to treat the fungus first, before I even want to treat the methane. And I only would treat the methane if the patient did not get better.
So what is your preferred antifungal in that scenario?
Look, I mean, we try to avoid the systemic ones as much as possible. I would say, and I know you have talked about this before in the conference, I mean, I use high-dose nystatin, and I increase the amount slowly because of the risk of die-off reaction. And we use biofilm busters to the best we can. And, and I think 2 out of 3 patients generally will get better using a locally acting antifungal. If necessary, then I may use iconazole, I may use fluconazole, and other things. But rarely I may go to iatroconazole, or voriconazole, and more systemic one. But as we speak, I have a couple of patients who actually needed to go to some of these more, powerful antifungals because they were not responding. But they have immune suppression. So, I mean, I won't be surprised, that they would need something of that nature. But as a first line for somebody who comes here, you work with their lifestyle, immune system, nutrition replacement, and just, protocols for antifungal, the diet and the nystatin.
Well, one of the reasons why I was so fascinated with this connection is because I did see it clinically, but I never actually thought of cause and effect with that yeast or Candida might actually be promoting methanogen overgrowth. And that was sort of like, when you said it, it was like a light bulb kind of went on. And I went, I do a lot of organic acid testing, and I see a lot of high fungal markers on that. I rarely see a stool test be positive, and I use a different type of stool test because of the different markers I look for. But I see it all the time that arabinose is elevated on an organic acid test, which is the marker for invasive yeast. I think it checks for these hydrolases or so that Candida secretes, and nothing on a stool test. So this is what I use a lot when I suspect Candida overgrowth or SIBO or LIFO, really, or just intestinal fungal overgrowth, because it's not location specific. So, I do now specifically see this, very high levels of methane also correlate with a higher arabinose. So I think this is just something that we need to investigate further. And one of the reasons I think it's great to discuss this is because I want to see if other people are seeing this as well. And if, what is the connection other than, is it that what you described as, providing an anaerobic environment? Is it the carbon dioxide? What is it that really drives methanogen growth in that environment? So I think that's really the question. If we can find that, that could potentially open the door for a new therapeutic intervention in a way. So anyways, I'm just thinking out loud.
And I think the persistence of also fungi, it generally implies to me that there's immune dysregulation in the form of the body's maybe reduced ability to deal with the fungal elements. That's why it becomes persistent. In one of our cases that the patient had received antibiotics, I can tell you when I did an endoscopy, I could almost see a biofilm on the small bowel. And when I did some scraping using a very like a ERCP catheter just to kind of look at, and I said, I'm going to bet this is going to come back PCR positive in high concentration of the fungi. And it did. Okay, so almost the point that it was visually, noticeable if you're kind of almost familiar what to look for. But it's an area that I hope it will ignite more research, and it gets formally studied. But I have concerns about treating, with neomycin, and rifaximin, because occasionally you see a paradoxical response. Sometimes people get, I got more bloated, I feel worse, or it didn't work. Okay. And that means that obviously there's another layer to think about. And mycophenolic acid commonly comes up in a lot of these urine tests. And we have seen sometimes really high numbers. And as you know, this is a drug that they use in the transplant industry to suppress the immune system. So, I wonder if these things are connected. Mycophenolic acid comes from penicillium. And penicillium, where do you find it? Hard cheese sitting outside. It could also be maybe from water-damaged buildings.
The whole mold topic, I had 2 mold specialists on the program, and we talked about elements of this. But the whole topic of mold is just so fascinating because we are seeing more mold illness, or I'm definitely seeing more mold illness, and there's various speculations around why that's happening. But getting back to, intestinal fungal overgrowth. Now, Candida is really one of those perfectly adapted to the human digestive tract because it has all these special features of changing morphologically from a budding yeast to a hyphae. And so it can change these morphological states. It can form biofilm. It can secrete proteases. It has all these sort of defenses with which it can evade detection, with which it can invade mucosal surfaces. It has quorum sensing. It does all this. So it makes sense that Candida is sort of like perfectly adapted for that. But my question is, do you also see other fungi be possibly involved? Like, what other fungi do you frequently see with not just methanogen overgrowth, but in GI disorders? You mentioned Rhodotorula. I see that a lot on stool cultures. How relevant is that at a +1 level? Do you see also Aspergillus? Do you see other types of fungi?
Aspergillus, I have not seen in a stool, but I also want to say that the only lab that I've seen that consistently cultures, fungal elements is the doctor's data. I know this is not a CME conference, lecture, so I use a name and I don't have an attachment to one lab or another. The name of these fungi is always a challenge. How do you say it? How do you pronounce it? How do you remember? There are over 100 species of these fungi. And I'm still sometimes seeing the laboratory reporting one other fungi that I've never heard about it. And I have to go and look them up and see what it is. But interestingly, majority of these fungal elements, when you study them, they're opportunistic fungi. So it's something you see in patients who are in the hospital or they have received transplant or under immune suppression. It is not something we would think we encounter in a person walking to the office. So even though the laboratory may put it as 1+ in the normal range, I don't believe this is normal because I've never seen anybody feeling good with that type of, scenario. And I give you a quick story. At one time, I had a gentleman coming to me with bad body odor, okay, and it was a very well built, and healthy looking person, but this is something that was bothering him for a long time. And we did a stool culture. It showed 1+ of these opportunistic fungi. And I said, well, did you know about this? He said, yes, I've had this for several years. But I said, did you ever get treated? He says, no. So obviously it became an area for us to target. But I did mention something to him. And I said, this is not normal to be there. You have another problem underneath it. This is just the tip of the iceberg. So I asked some questions whether he deals with pets and animals. And apparently there were some cats around. Okay, and the test for Bartonella came back positive. Okay, so obviously this was sitting in the background, and the markers were clearly positive, so it was not a questionable thing, at least in my mind there. And we have seen other cases like this, with a little bit of a different variation, if you will. But I think it would be prudent to have what I call onion thinking, that you need to have layers 1, layer 2, layer 3. To see what might be sitting in the background.
Do you have SIBO and want to learn how to help yourself? The SIBO Success Plan is now available from thesibodoctor.com. In this highly anticipated plan, you'll learn my tried and proven method to treat SIBO, including home treatments, online dispensary guides, diet handouts, and much, much more. Already being treated by a practitioner? No problem. The SIBO Success Plan is designed as a standalone program or to work under the care of a practitioner. Become a SIBO-savvy patient and beat SIBO for good. For more info, go to www.thesibodoctor.com.